Okay, so let's make a start. So good afternoon, everyone, and welcome to the webinar. So my name is Kieran Stevens, and on behalf of Williams Medical, I'd just like to take this opportunity to welcome everyone to this webinar on what is certainly a hot topic at the moment, the 10-year plan and you. This webinar is the fifth in our new practice support series and is presented in partnership with the Institute of Health and Social Care Management. We're delighted to welcome John Wilks, Chief Executive Officer of the Institute today. So thanks for joining us once again, John. And a couple of bits before John introduces himself. So in terms of housekeeping, this webinar is scheduled for 1 hour. In terms of questions, we'd like to invite your comments and questions throughout the session. So if you do have a question, please use the chat function, which should just be at the top of your screen. And good news, we know it's working because some people have already said hello this afternoon. And a final point on recording, this session will be recorded and will be available on our platforms shortly after the session. We'll also include some useful resources in our post-event communication. So without further ado, I'd like to hand over to John to start the session.
Oh, thank you, Kieran. Hello, everybody. How lovely to see you all. Thanks for giving up your lunchtime. We're going to have a flick through for about 45 minutes, something like that, and then open this up to questions. I recognise the names of some of you here, so I think I've met some of you before. Others I haven't had the pleasure yet, but the way this will work, we're very happy to make this pretty informal. If you've got any questions as we go along, or you've got any opinions to voice, you're very welcome to pop your hand up and I'll come to you. When we do come to the official kind of questioning session at the end, you're very welcome to use the chat, or indeed, as I say, pop your virtual hand up and we'll come to you. But thanks for coming along today. I know it's a big ask given what you're all busy with at the moment in the land of primary care. So I know that myself and certainly Williams Medical really appreciate it. We will try to reciprocate by giving you a bit of an insight here. We're looking at the 10-year plan today, the NHS 10-year plan published earlier this year. And what I'm going to do, I've thought long and hard about how do I tackle this? You know, some of you probably know the key points of this anyway. So I'm really going to just try to pick it apart from the point of view of practicality in respect of what this means for all of you working in primary care and what are some of the practical applications that you might choose to take from it, okay? And then we can perhaps have a bit of a wash up towards the end, okay? So I thought I would start with this, which is not an unfamiliar chart to many of us, whether you work in the NHS, social care, or you're just a patient, a regular citizen of England. But this is the NHS waiting list as of most recently, September 2025, most recent stats available. And the reason I put this up is because the Labour government was elected as one of the key parts of its manifesto on the basis that it pledged to bring wait lists down in the same way perhaps as the duo of Gordon Brown and Tony Blair did many years ago now. They promised as one of the, I think, 5 foundation points of their manifesto in the lead up to the last election that they would bring wait lists down. They didn't say to what, they just said they would bring it down. So you might want to just keep your eyes open for a bit of wriggle room in that regard. But I think it's really important that we say that is the core manifesto promise that the Labour government made in the run-up to the last election. Why is that important? Well, it's important because they're elected, as every political party, unless something goes drastically wrong, is on a 5-year electoral cycle. You would look at that now and you would say, okay, we are now, no, we're not far off 2 years, I suppose, certainly 18 months in. So we've got 3.5 years left of the parliamentary mandate. Where are we in respect of that core manifesto promise? And where are we in respect of reform of the NHS and so on? And I think it's interesting in that regard to pop up what the first major move was. This predated the 10-year plan. This was in March this year, where it was announced by the Prime Minister, Sir Keir Starmer, in collaboration with Wes Streeting, Secretary of State for Health and Social Care, that NHS England was to be abolished and would be merged with the Department of Health and Social Care. No mention of this in the manifesto. Uncertain what the implications of this are in respect of lowering the wait list, which, remember, was the key manifesto promise. But I think that was, in the context of the 10-year plan, an absolute bombshell that is still, the reverberations are still being felt across health and social care, certainly in England. Okay. Why is that important? Well, because in July of this year, the 10-year plan was launched. Now, I confess to being, and I'm not a political being, I'm just going to tell it as it is. I confess to being dumbfounded that 3 months before this was published, they announced that the NHS England was being abolished and was going to be merged with the Department of Health and Social Care. I was astonished that there was no plan in respect of what was going to happen to the 15,000 people who worked directly for NHS England. And I was thunderstruck by the fact there didn't seem to be any Treasury support for that move. So immediately I began to think, okay, we've all been waiting a long time for this 10-year plan. We'd had the previous long-term plan under Sir Simon Stevens, then CEO of the NHS in England, that came along, 2017, I think that was. This was the major thing that was going to say, how are we going to go from there to there? And this is post-COVID, most importantly of all, if you remember. So I kind of looked at it, I thought, that's interesting timing, but let's see what's in it. I'm going to just take you through some of the basics. Some of this you will already know, okay? But these were I call them the three strings of the plan, that we would go from hospital to community, analog to digital, sickness to prevention. I don't know whether any of you have ever heard a three-string guitar. It's not the sweetest sound. And the thing that made me worried about the 10-year plan in particular was the fact that whilst they may be perfectly laudable objectives, they're fairly straightforward for anybody who's worked in health and social care over the last 5, 10, 20, 30 even years to think, well, yeah, of course we would want to do that. The big question is, how? And even if you get the how right, the next big question is, what's the implementation plan? What's the time scale? How are we going to do this? Given that we're internationally perceived, certainly in terms of general practice within the United Kingdom, internationally perceived as efficient. We have some of the lowest admin costs per head of population that we serve. And we are perceived to have good financial protection for our patients by the fact that this is a system that is based on universal taxation. So there wasn't really anything there that made me kind of sit upright in my seat and go, ooh, crumbs, this is new, this is different. What I was interested in was, what's the implications of this for the different strata of health and social care, be that domiciliary care, residential care, mental health, primary care, the acute sector, tertiary sector, charities, etc. What are the implications of this, and are they detailed? Well, let's have a look at the court of public opinion. This is all common knowledge. This is from publicly produced and available documents here. The first one here, this was the NHS parliamentary investigation in 2022 that acknowledged that general practice is the beating heart of the NHS, and when it fails, the NHS fails. And then if you looked at the Health Foundation in 2024, they made clear that the public wants the government to focus more on improving primary and community care than hospitals, and is willing to pay more tax to accommodate that. There we go. John, that's an interesting point. You're saying your initial thought it was a rehash of our health, our care, our say. That kind of resonates with me. It just felt like, well, of course you would want those three foundation things to happen. Who wouldn't? Tell us how it's going to happen. But what I wanted to bring up first of all was the court of public opinion around primary care, which is actually we're doing a half decent job here anyway. Please don't pin any of this broken, inefficient, bureaucratic demands reform kind of dialogue that has been coming out of the government recently. Please don't be pinning that on primary care. I think primary care has been doing a magnificent job, given the resources and people that it has available, serving an aging and increasingly demanding population. So I think that court of public opinion rather backed this up. It was saying, make sure that public health, that primary care and public health is looked after. We would be prepared to pay more in tax to make that the case. How about this then? This is primary care and the plan. This is directly taken. I will have to read it out for you because I think my face may be blocking some of this. But this was actually taken from the 10-year plan. The status quo of small independent general practices is struggling to deal with 21st century levels of population aging and rising need. Without economies of scale, many dedicated GPs are finding it difficult to cope with rising workloads. Far too often, that means work is causing chronic stress and mental illness among hard-working professionals. Many GPs are voting with their feet. 74% of fully qualified GPs were partners in 2015 compared to just 55% today. Where the traditional GP partnership model is working well, it should continue. But we will also create an alternative for GPs. We will encourage GPs to work over larger geographies by leading new neighbourhood providers. I have to confess, I don't know whether any of you have read that particular paragraph before in the past. I found that some of that was reassuring, but some of that was really rather worrying and anxiety inducing, particularly the last bit where it started talking about we will encourage GPs to work over larger geographies by leading new neighbourhood providers. The key word there being leading. And I haven't seen any evidence of that, for example, in the integrated care boards that were a fundamental feature of the last reorganisation of the NHS. Anyway, that's what the plan says for primary care. Let's just start to ease you through what some of the implications of this. And thank you, Sergio, for your comment there. I will come back to that a little bit later on. Okay. First and foremost, let's have a look at what the actual situation is in terms of GP workforce. And that doesn't make terribly reassuring viewing. In fact, you could probably reasonably look at that and say the numbers are at best static. If you look at the number of partnerships, has already been alluded to, they have reduced. The number of salaried GPs has increased. The number of trainees you could look at that, so it's pretty static really. Number of locums, pretty static. We're not really, if we really want to put primary care at the heart and start of this 10-year plan, then you would have to look at that and say, well, they don't seem to have the workforce in place to be able to reliably deliver upon that. Okay. And if you think that's the case, well, let's have a look at the first tenet of the 10-year plan, which was this idea of hospital to community, what that means for all of you working in primary care is that you are going to be encouraged to become more multidisciplinary, work with locally based mental health, physiotherapy, tertiary services, and so on, to start to bring alive this idea of we can do more in the community than we could reasonably do in the hospital. I'm worried about where's the infrastructure investment to enable this to really properly happen. And in any case, haven't we been doing this for years? And Sergio points to the neighbourhood centres, a rehash of the former Darcy centres, which came and went. I think the Darcy centres did come and go. I don't think they were properly funded. But there's an interesting photograph. Does anybody know? I know it says Bromley by Bow Centre, but why would I put that photograph up there? Would anybody like to put it in the chat or raise your hand and propose something? Why have I chosen to put that photograph up if we're talking hospital to community? And by the way, this is designed as an interactive workshop, so feel free to, impart your immense wisdom to this as we go along. It's a successful example of all-round holistic care. Indeed it is, Karen. Bromley by Bow, this is Sir Sam Everington's practice. This was the advent, effectively, of social prescribing back in the early 2000s. I've met Sir Sam on a couple of occasions. I've been to his Bromley by Bow Centre, indeed into that building. And of course, what you realise when you go in there is this was the blueprint, I would suggest to you, for this hospital to community approach. Sir Sam and brilliant other people who came in with him have absolutely nailed this, I think, where they assemble under one big roof there, and it is a big building, I'm happy to report that, but they assemble all of the services that the local population would reasonably find useful to address the health and care needs that they reasonably have there. I don't know, Karen, whether you've ever been to Bromley by Bow to have a look at that, but it works beautifully. And I remember going there, interviewing some of the patients who are being looked after there. There's everything under one roof. There's local authority housing advisors. There's debt advice. There's nutritional advice. There's advice and guidance for people who may be struggling with substance abuse or alcohol dependency. There are language lessons in an environment where English is a first language. I think it's only at about, I think it's 8 or 9% when this first started and so on. So they really kind of brought the services together under one roof where this could be sensibly done. I think that Lord Darcy tried to amplify this approach, and I don't think it was properly funded, but actually this blueprint has been in place for a considerable period of time. And actually, I think that's really what the neighbourhood centre idea is. I think it's get the services together that can enable a local population to be properly looked after and enabled to stop getting sick in the first place. Okay, let's move along if we may. I'm just going to move that example out of the way. This is what neighbourhood health is spoken about within the plan. It says general practice and community services need to be the cornerstones of neighbourhood health, but are under immense strain and lack the capacity to lead this shift without significant support. The plan does not address how already overstretched primary care or community services staff will be resourced or empowered to take on expanded leadership roles in neighbourhood care and develop the skills they will need to co-create services alongside communities. This is from the Health Foundation, by the way, who came up with this commentary on the plan in respect of the neighbourhood health policy. Actually, I'm not sure I agree with this. I rather think that there are plenty of people within primary care right now, many of you may even be on this call today, who actually know how to do this. All you're waiting for is some liberation and sensible investment to come in to enable you to bring disparate groups together under one metaphorical roof and start to address local community needs. I think we've actually got the skills that we need to do this. We simply need to be given the encouragement and liberation to get on with it. It remains to be seen whether, of course, that will come along. Let's have a look at the next foundation pillar, though, if we may. This is analog to digital. So this is all talking, as you would expect, around from a general practice perspective. How do we improve patient access? And there is a huge section in the 10-year plan about online bookings, questioning, and so on, probably AI enabled to enable people to interact with their general practice online without having to, I'm going to use inverted commas, bother the GPs, nurses, and staff that are there anyway. There seems to be a huge amount of reliance, hope, expectation, positivity around an expanded NHS app and what that will do to enable this to advance a little bit further. And there's a huge amount of talk in the plan about new tech to improve efficiency and reduce administrative burden for staff. The one question that I'm a little bit worried about is the I word, which is interoperability. So at what point will funding be provided and will planning be undertaken to enable the disparate systems from across areas to actually interact with one another reliably? You know what I'm talking about here, those who are on EMIS, System 1, etc. How do we reliably get those systems to interact with hospital systems, tertiary systems, etc., so that any one citizen at any one point in time can have all of their details with their permission accessed by multiple service providers? I think that is actually much more important for most patients than just talking about improving patient access via online activity. That's just my view. I'm just kind of putting up here what's in the plan, so please don't shoot the messenger at this point in time. Okay, and yes, thank you, John. Region to region, holiday makers, etc. Yeah, if you've got sick outside of your immediate region, you know just how difficult that is if you're on holiday. Let's have a look along here. The other thing I'm kind of concerned about in that regard is the GP contract 25-26. Many of you will be across this, but where we're talking there about specific aspects of that in respect of enhanced services for groups with similar needs and so on, you being encouraged to either join a single neighbourhood provider or multi-neighbourhood provider within this the context of this contract. I think a lot of this will have to be dealt with in terms of this analog to digital approach. There has to be technical support for this. There has to be real, reliable digital support for this to enable this collection of neighbourhood provision to be successful. Without that, I think we can talk all we like about enhanced services for community groups, but unless we can get the tech right, I fear that that's a well-intentioned aim, but it may not necessarily be an immediately achievable goal. Okay, just my view. I'm happy to discuss this at some length. And then the final foundation principle of all of this was, of course, sickness to prevention. The idea here, of course, is that we should be aiming to reach patients earlier via intelligent use of things like population health data, AI, and enhanced systems. We want to try to make sure that healthy choice is the easiest choice for people to make. And by the way, I think we can expect in the budget today to see some further taxes on ultra-processed foods and sugar to try to enhance public health. I'm worried, though, perhaps, I mean, if you talk to the Royal Society of Public Health on this, and I would encourage you to go and look at their website, pick up some stuff off of them. They're proudly independent, good people who work there. We know through the Institute, the chairman, Johnny Pearson Stoddart, who's a fantastic advocate for public health. And he says he's a bit concerned there's too much focus on consequence of poor health rather than the cause of poor health. So how do we upstream the whole business and address, dare I say it, the elephant in the room, which I'll come to in a moment. Overall for you, I think, this is the kind of take that I have from all of this. Who's going to lead locally and how? If the integrated care boards are anything to go by, even if we talk about neighbourhood health centres, even if we talk about neighbourhood health services, I worry about how will those be formed, putting primary care in particular at the heart and start of them. And I think that's up to you on this call and your colleagues and your fellow providers within your regions to really make your voices and opinions heard. I think you are probably the best designers and architects and understanders of what is needed in your local neighbourhoods. The danger is that you'll be shuffled down routes by nationally approved directives, or worse still, by hospital-based interest groups who want you to pick up the pieces of stuff that they find challenging to address. That rather worries me. So I think make your voices and opinions heard, be in prime position to be able to say this is what we need, and be able to articulate locally what you think the local population and community require. In other words, don't be afraid of coming up with your own neighbourhood health plans, perhaps by invoking support and help and discussion from friends and colleagues in local authorities, community nursing, the care sector, be that residential or domiciliary, and then some of the charity providers that you have available to you. I would start to think to yourself, how can you take the lead on this now rather than waiting for something maybe down the pipe to be imposed upon you? Okay. The next thing is this. It appears this has been widely leaked. It would appear that £300 million will be made available in today's budget to enable the rollout of these neighbourhood health centres. It's talked about 250 of these centres being, it says, built within the plan, but I'm uncertain. I can't see within the 3.5 years that this government has left within the parliamentary cycle. I'm concerned whether there's going to be any really physical building work undertaken, or whether this will be more of a virtual connection of services within the neighbourhoods, perhaps with some locally provisioned offices or something of that nature. It kind of makes me feel about, my son was Marius in Les Miserables some years ago, and he was obliged to sing empty chairs and empty tables. And it kind of, as soon as people start talking about we're going to roll out the building of 250 new neighbourhood health centres, I start to think, yeah, but who's going to staff them? Remember, right now, there is no 10-year workforce plan. It was expected towards the end of this year, but they can't agree it with the Treasury. And without a workforce plan to support how are these neighbourhood health services going to be delivered, I'm rather worried that this is a rather cosmetic exercise. If I can move along, though, I think from your perspective, I would encourage you to have a look at what you can do with your existing technology. I would encourage you to partner with other providers of health and care within your communities and have meaningful discussions about what you have, what you can make available, what you can put into a pot so that you can assemble all of this data together and really start to address some of the key factors that you know are prevalent in your individual communities. In other words, what I'd probably be doing if I was you is I would be doubling down on the successes that you've had, and I would be listening to the successes that your fellow providers of health and care in your communities have had, so that you can mass together and, as I say, start to be the architect of these newly minted neighbourhood health centres. Okay, just before I get to some of the questions in the chat, I just want to have a look at this. I think this is the big question, and it's not really addressed in the 10-year plan. And I think if we don't address this, then primary care will continue to be under pressure, under strain, and despite the well-intentioned words about moving from hospital to community, you will be the ones where people are turning up with the problems that are in some respects self-induced due to circumstances. And the big question is, how do we stop people getting sick in the first place? I think that's the elephant in the room, if I may. And the disappointing facet is, despite the fact it talks in the plan about from sickness to prevention, there isn't really a coherent, cohesive plan that lays out how this is going to be fundamentally addressed. There is, as I say, I think there's going to be some taxation around ultra-processed foods and sugar in the budget, but we need to go way beyond that kind of stuff. We've really got to go into promoting healthier lifestyles. We've got to review, I think, education in schools and such like, and we've perhaps got to be starting to look at the cultural sensitivities within our communities and figuring out how we help people who are most vulnerable. All right, so I've prattled away as best I can. Can I just ask, how many of you on the call right now, please just put your thumb up. How many of you have read the 10-year plan from cover to cover? Not seeing many thumbs go up. It is, I think it's 168 pages, if I counted correctly. So I'm not necessarily surprised to say that it's a big old read. But isn't that extraordinary? All you guys responsible for delivering primary care in your local areas, and hardly any of you have been able to read it. I'm not surprised, as I say, you're all busy people. It's a heck of a long read, and a lot of it is kind of hospital based, as you might expect. But it's disappointing a little bit in that regard. Okay. All right, so I'm going to open up to questions here. If we may, I'm going to have a look at some of the stuff that people have been posting as we've gone along. And you're welcome, by the way, if you would like to put some questions in the chat, I will do my best to read through those as we go along. So Sergio says, if primary care is deemed to be very cost effective and efficient, then surely investment would be made in the most efficient part of the health service. You would get a better return on investment. I don't disagree with that, Sergio. The question is, what should we be using the money for? So we seem to have a situation of going back again. This is a really important thing to remember. In March, it was decided that NHS England would be abolished and it would be merged with the Department of Health and Social Care. I know fact that this is an absolute mess at the moment. There's no certainty. The decision making has been compromised. The idea of how we plan and strategize the rollout of the 10-year plan has been compromised as a result. And my worry is if all we just say is give us more money in primary care without being enabled and empowered to decide how we will spend it with our colleagues from local authorities, care, mental health, community nursing, tertiary and charity sector, unless we're liberated to decide how to spend that money, it will just go. It'll sort of disappear on perfectly worthy ideas, but it won't necessarily provide that cohesive, coherent neighbourhood health structure that we would all, I think, aspire to. And as I said, I don't disagree with you about the Darcy centres. Okay. Sergio again, is there likely to be an appropriate redistribution of funding to enable, I think you mean the concept of neighbourhood health in the community, to work properly as distribution of the relevant workforce is inequitable? I think refer to my previous point in that regard, if I may. And I think one of the reasons ICBs are in the process of downsizing is partly to do with this abolition of NHS England. It's partly to do with the fact that, frankly, in too many areas of the country, they haven't worked. You know, they've been in place for what, nearly two and a half years now. If somebody said to me, come on, John, put your mortgage on it, write down 3 things that manifestly nationwide they've achieved, I am really struggling with that, really struggling with it. Okay. John, thank you very much. John, who was one of the people who has read the 10-year plan, he says he's an academic and it was a light read. Bless him. There we are. Okay, do we have any more questions at all? I'm very open to them. Has anybody would like to know about something that maybe I've not covered within the plan, within my commentary? Well, can I ask a more fundamental question in that case? Are you happy with what you've read about within the plan as I've discussed it? Are you happy with what is in there for you? Are you happy about this advent of neighbourhood health centres? Do you feel listened to and involved in all of that? Please help me by responding. Otherwise, I think I'm speaking into the ether here. What do you feel about it? Anybody at all? You're very welcome. I'm here. I'm all ears. What do you think from your own perspective of this 10-year plan? Are you happy with it? Are you anxious about it? Are you disturbed by it? Deeply worried and stressed by it? What's the overall feeling here? Thank you, Sarah, for rescuing what was beginning to be an embarrassing situation. Thank you. Go ahead. What do you think? You're on mute at present, by the way. Oh, all the microphones are muted, apparently. Kieran, can you help with that at all, I wonder?
Yeah, bear with me. I will allow Sarah's mic in a sec.
Hello.
Hello, Sarah. We've got you. I was wondering why nobody was speaking. Now we know. Lovely. Here we are. Welcome from Ramsbury Surgery, Sarah. Lovely to have you with us. What do you make of the plan? Have you read it? Are you happy with it? Are you concerned by it?
No, so I think I certainly have not read the whole thing. I loved your question saying, have any of us read it? Because I think, as you say, there are bits of it that are just so detached from primary care that you sort of skim read things as practice managers, exactly. And you find that from going to practice manager meetings, IT meetings, ICB meetings, etc., that you pick up nuggets of things from colleagues and from meetings. So I know it might sound not the thing to say, but we very rarely read something from cover to cover, because by the time you get halfway through it, you've picked up lots of it from colleagues and from Facebook groups, practice manager groups, that kind of thing. And you find that you just focus on the bits that are either going to affect you or that worry you, or that you can completely ignore because you sort of know that it's actually not really going to impact you because the likelihood of you being able to do it is so small, kind of thing.
I understood.
If you get what I mean, kind of thing. So
could you home in for me on the neighbourhood health centres? What's your feeling about that? Because my feeling, all the feedback I've received, and I get letters and emails from all sorts of people, a lot of people are saying, do you know what, in our area we've been doing this or something akin to it for years. You know, we've deliberately forged really good relationships with all sorts of local authority, charity sector, care provision, mental health services and so on, physiotherapy services. You know, we've got that. We've worked really, really hard, and actually it's delivered really well for the communities that we serve. So I was a bit surprised when I saw that it's almost being mandated, and my worry is it will be overly directed from a national perspective rather than genuinely empowered locally.
Yeah, and I think that last bit that you've just said is exactly it, really, because I represented a large group of our practice managers at a huge, I can't remember what they called it, whether it was sort of a brainstorming session kind of work. I think, no, they called it a workshop for secondary care, primary care, third third party sector or whatever they're called, voluntary sector, etc. And we had this amazing meeting in this huge warehouse kind of place, where one of the biggest things that people were saying was we've got to use our charity section, our voluntary sector more in healthcare. And they were all crying out for more interaction, more communication, more use, all this kind of stuff. And it was a really, really, really positive meeting. And we all came out with really good feelings about what we were going to be able to do.
Yeah.
And a few months later, I wrote to the ICB who had organised it saying, I understand you were going to be pulling something together now for us to distribute so that we had something to work with and, you know, to go forward with and move on with. And I've never heard anything since the meeting.
No.
And so you get these amazing days where everybody sits around saying what they'd love to do and what would be so brilliant, and all these incredible voluntary sector companies were all there with amazing resources, and then it just sort of falls flat.
Nothing. Yeah.
And so
it's heartbreaking, really, isn't it?
And I think for those of us who have been in primary care for more than 20 years kind of thing, you've been round the circle so many times that you become a bit sort of, oh, here we go again. You know, I remember the days where we had our district nurses sitting in the offices with us, you know, all that kind of stuff, your midwives in with you.
Yeah.
The doctors could walk down the corridor and speak to a district nurse. You know, they could phone a consultant at the hospital and say, can I send you this patient? You know, all this kind of stuff. And now you get to the point where you see these huge documents and you just sort of go, well, I'm just going to sit and wait to see what actually happened.
Yeah.
And you find that all the different surgeries do different bits of things anyway. So
well, that's rather my point, is that as Sergio says, there's no one size fits all, you know, and I think that needs to be amplified. You know, your local communities are your local communities. They all have different needs, different perspectives. They have different demand calibrations and so on. It should be different. It should be individually designed. And as I said, I think my advice to you is become the architects of your own destiny. You know, do another one of those sessions, but under your auspices. Bring people together and you start to design up what you would like to implement in your neighborhood. Figure that out then you'll have a whole cohort then of supporters keen to do it that way and so on. And I think that way you've at least got something to put in front of any of the powers that be that may appear and say, this is what we want to do. You know, there's a reason Sir Sam Everington got his sirship, and that was because he was brave enough to just get on and do that thing in respect of social prescribing. He just brought people together and he just got on with it, basically. And maybe he broke the mold, maybe he's a revolutionary, but I'd rather be that than just waiting for somebody to do something to you that you may not necessarily approve of. But thank you for your observation, Sarah.
Or waiting for funding. I think sadly we have sort of gone. I know that funding is really, really tight in primary care and stuff now, but I think sadly sometimes in primary care we sort of wait for there to be a price attached to doing something, which I can't believe I'm saying as a finance manager.
You know how much, but you know how much money's coming down the pipe to you. You're going to get 300 million, which is a drop in the. I mean, it wouldn't even keep the NHS lights on for 24 hours. 300 million is going to be made available. My suggestion to you would be, you know, if you're one of 300 neighbourhoods around the country, or 250 neighbourhoods around the country, you figure out with your colleagues across the different service providers, if we get given a share of that, which let's say is going to be 1 and a bit million, what would we do with it? And figure that out. So you've got a blueprint, you've got a plan. As long as you get the money, this is what you're going to do with it. And draw yourself together. You could do it as a community interest company, something like that, or just get people together with a like mind and figure out how you would design it. And that's, to me, if I was in your shoes, I'd be finding ways to do that. But that's just me. Easy for me to say from here. Surja says, has the growth of performers enabled better access or worse? General practice has to do with hundreds of them. If they're not filled out correctly, sent back. Yeah, that must be very frustrating, Surja. But what can I say? If we know that's the case, that's the case. I think just maybe make some placards and start to march up and down outside your local general hospital or something like that. I'm being a bit facetious there. Any other questions at all from anybody before I hand back to Kieran? It's interesting that John Ellis, who has read the whole plan, like me, he reaches a similar conclusion to me. It's a light read. If this was a marking of a dissertation, this would be a borderline pass at best. Don't disagree with that at all. And the key bit that's missing from it, by the way, is that there is no implementation chapter. So nowhere does it say, this is how this is going to work. These are the timescales, the strategy, the rollout plan, etc., etc. My big worry for it is because of the chaos around NHS England and Department of Health and Social Care merger, I suspect that large parts of this will be kicked into the long grass. And West Streeting is unfortunately rapidly running out of time to do anything genuinely impactful in respect of the wait lists. Remember, it's the wait lists which will determine whether this government is returned in 3 years' time or not. All right, Kieran, I think they've run out of steam, everybody here. I hope they've enjoyed their sandwich while I've been prattling away, but I'm going to hand back to you if I may.
Thank you, John. Lots of thought-provoking moments there, and yeah, really informative session. I'm sure everyone on the session will agree. We've still got a little bit of time, so if you've got a question that you've not yet submitted, please pop it in the chat box, and yeah, we'll get through as many as time allows. Conscious we have covered quite a few already. I am pleased to confirm that we'll be delivering more education in the new year, so please keep an eye out on our social media channels along with our webinar registration page. I'll pop the link to that in the chat in a second. But yeah, our next session will be on systems leadership in primary care, and we'll have Susan Jones joining us after Christmas on the 14th of January. So yeah, please register for that event. Yeah, it'll be the perfect follow-on to this session. The good news, throughout all the potential change that we've discussed today, Williams Medical will be here to support you as one of the leading partners for healthcare professionals in primary care. We are dedicated to supporting you every day, both from a service perspective and also through added value and education, as we've been able to deliver in partnership with John and the Institute today. I just want to remind you that you can earn rewards every time you shop with Williams Plus. This is our reward scheme at Williams Medical, and this applies to products in our disposables, pharmaceutical and equipment categories, as well as our various medical services. You can find out more about your eligibility for the scheme and enrol by visiting wms.co.uk/Williams Plus. Before I bring the session to a close, I'm just going to double check the chat, John. I don't think anything else has been added in. A couple of nice messages. Thank you, guys. Okay, so yeah, once again, John, thank you. And thank you all, everyone on the session, for joining us today. As we said at the start of the webinar, we'll be forwarding up with some resources over the coming days. And yeah, please don't hesitate to contact us if you need any support. And I'm sure John would be quite happy for you all to reach out to him directly if you've got any questions as well. So yes, we look forward to seeing you all on more webinars, including our practice support series in the new year. Thank you all for joining. Enjoy the rest of your day.